And let us know how many are there.
Yes, sir, we are live already. So, should we start?
Yes.
So, good
Uh,
evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is a digital partner of this event organized by National Neonatology Forum. And the topic of today's session is NNF Shine Week 1 West Zone. So let's begin today's session, for which I would like to hand over the session to Dr. Rishikesh. Sir, over to you, sir. Kindly proceed with your talk.
Ramesh?
yeah, please.
Okay. A very good evening to you all. It's indeed a pleasure and privilege to be part of a short course in neonatology by NNF. My sincere thanks and gratitude to our President, Professor Dr. Sushma Nangia, and our Honorable Secretary, Dr. Surinder Bish, for giving me this opportunity.
Thank
So
you.
let me walk you through the first week's module on two topics. First is care of the newborn, and the second is on thermoregulation. Okay, you are on the postnatal rounds and you find a baby's temperature to be 36 degrees Celsius. This baby it needs to be shifted to NICU for IV fluids and further care. What do you think is the answer? Yes or no? So as we go through the slide sets, you will get to know how do you approach such an infant and how do we make and fine tune our management. So let me start with the care of the normal newborn first. And the story of the newborn starts with uh, these objectives that we need to keep in mind: providing care at the time of birth, screening these babies for visible defects, and providing postnatal care for all normal babies. So let's look at the care for the baby at birth. So the story begins in the delivery room, and we do realize that almost 90% of babies would establish spontaneous respiration and cry and would not need any steps of resuscitation. But what is required is preparation on our parts, simply because absence of risk factors does not rule out need for resuscitation at birth. And therefore, at the time of birth, it is mandatory that a designated personnel well skilled in basic newborn resuscitation be available, who would be able to perform initial steps and provision of bag and mask resuscitation. What is equally important is that the concept of golden minute of establishing ventilation not later than first minute of life. But mind you, majority of the babies would not need any form of resuscitation. And what is therefore expected for all those babies, term or preterm, who establish spontaneous respiration and cry, is this step, which is today the key step to be performed for all vigorous newborns, whether term or preterm. And that is delivering the baby on the mother's abdomen for and providing warmth, providing cleansing, ensuring that the wet linen is removed. And all these steps happen on the mother's abdomen. And what is important to note is these steps take place with the cord being intact. So, what it means is that we would not hurry in clamping the cord in the first minute of life for all well newborns. And we would continue to provide what is therefore called as delayed cord clamping for all well newborns, both term and preterm, for this has immense benefit, short term and long term. So cut the cord after first minute of life is the message for all healthy newborns in the delivery room. What is equally important is that there should be zero separation between the mother and the baby, and this gives us an opportunity to ensure that the baby and the mother remains together in skin to skin contact, what is today called as zero separation. This has immense benefits for the baby, so also immense benefit for the mother. And therefore, two simple interventions, low cost, effective, scientific, evidence based, which should be performed for all healthy babies at birth. One is practicing the art and science of delayed cord clamping and ensuring that there is zero separation with continued skin to skin contact between the baby and the mother. Having said that, it is equally important that we should ensure that the baby is put onto the mother's breast within the first hour of life as early as possible. And what is expected of us that it has to be exclusive on demand. And this means that there has to be a supervised assistance to all mothers at the time of birth or thereafter, so that the early breastfeeding is initiated within the first hour of life. And therefore, uh, following the delivery room stabilization in the form of delayed cord clamping and early skin to skin contact, there has to be a third intervention of early and exclusive breastfeeding within the first hour of life. Thereafter, we would weigh the baby, and this is a simple tool by which we would be able to classify the baby based on the weight as low birth weight, very low birth weight, or extremely low birth weight. This in turn would help us to risk stratify which of these babies would need special care. What is equally important is before you leave the delivery room or within the first hour or so, you should be able to do a head to toe examination to rule out presence of any abnormality, congenital anomaly, and be able to define whether the baby is well or sick or is likely to be potentially unstable and would need further evaluation. As per the recent RBSK operational guidelines, it is equally important that we do a head to toe search for both obvious and occult congenital anomalies from head to toe. The occult anomalies which are likely to be missed in the delivery room are those of the eyes, those of the oral cavity, uh, those of the spine, genitalia, and therefore they should be specifically looked at so that they should not be missed. And so also ensure that the upper and the lower orifices are patent and there is no abnormality per se in any of these. So a head to toe examination for common birth defects is the next priority for us. Within the first 24 hours, it is mandatory before the baby leaves the delivery room or as early as possible to administer vitamin K. The objective of administering vitamin K is to prevent what is called as the hemorrhagic disease of newborn previously. Today, it is called as vitamin K deficiency bleeding. And the dose is 1 milligram for all babies who are above 1 kg versus a dose of less of 0.5 milligram for babies less than 1000 gram. This dose is given intramuscular. Before discharge, the baby must be administered 3 vaccines. The important ones that should not be missed are the BCG, the oral polio, also called as the zero dose of polio, and hepatitis B vaccine. But remember, the first vaccine that the baby receives is the mother's breast milk, which is a big immunomodulator per se, and therefore every attempt to ensure colostrum and early breastfeeding should be made before we go on to administer these vaccines. So, what did we learn about routine care? For all healthy term and preterm newborns who have established spontaneous respiration and cry, we would ensure the baby is delivered on the mother's abdomen. We would continue to support and promote skin to skin care, cut the cord at the end of first minute, and initiate early breastfeeding and have a zero separation policy as far as the baby and mother is concerned. Few don'ts that we need to keep in mind in the care at birth and in the immediate period is not to apply any substance to the cord, no routine role of oral eye drops, no early clamping of the cord, not allowing the baby to remain naked ever, and holding the baby upside down or tapping the baby or continuing stimulation in a baby who is not breathing at birth is not a good policy in terms of care. Lastly, before you leave, it is mandatory that you communicate with the family, inform the birth weight, gender, and the condition of the infant, and more importantly, confirm the gender and the identity tag with the family before you leave. What is equally important is as the baby gets shifted to the postnatal ward, you would continue to evaluate the baby for tone cry activity, for maintenance of temperature, adequacy of breastfeeding. What you must ensure at every opportunity for evaluation for the newborn is presence or absence of jaundice, and more importantly, assess the adequacy of breastfeeding by looking at the color, frequency of the urine, and so also of the stools. And at any time, you have features which would alert you to the possibility of danger signs. Such babies need urgent evaluation. There are certain things that you must be aware for normal newborn, and these include a weight loss, which is physiological, that is seen for both term and preterms. What is important is the weight loss may be up to 10% for term babies, which is regained by the first week of life. But for preterms, the weight loss may be to a tune of 10 to 15%, and which is regained by 10 to 14 days of age. Any weight loss more than 3% of the birth weight per day is pathological and needs evaluation. And this means that you must focus on adequacy of feeding. A baby who has enough mother's milk would pass urine frequently and it would be clear, and the baby would be quite quietened once the feed occurs. And at the end of first week thereafter, a weight gain of around 20 to 30 grams per day would be acceptable. The baby otherwise is alert, active in between, and following feeds goes to sleep with frequent urine and clear color of the urine. What is important is not to miss a jaundice, which is seen in 40 to 60% of normal newborns. Traditionally, we have looked at assessment of the color, looking at the head to toe evaluation, dividing the body into 5 zones, what are called as the Kramer's criteria. Today, we realize that there are limitations in our visual assessment, especially in the first 72 hours of age, where you are likely to make an error based on the color, based on the pigmentation of the baby, exposure to sunlight, presence of adequacy of natural light, and more importantly, it appears to be subjective and there is huge intervariable uh, uh, assessment changes that are noted. So an objective way, if facilities exist, is to do a transcutaneous bilirubinometer whenever you find a baby to be discharged, or you find the baby to be icteric. What is equally important is that in your first assessment, you should be able to identify which of these babies have a pathological jaundice. So a baby who is having a poor tone cry or activity, appears drowsy, the mother complains that the feeding is not adequate, or on evaluation, you find this baby to have palar plethora, hepatosplenomegaly, or evidence suggestive of sepsis. All of these would suggest that this is pathological jaundice. So, what is equally important is to evaluate the jaundice, looking at the gestation and the weight loss. And we said any weight loss more than 3% per day is pathological, and preterm babies do not follow the rules of the game, and therefore preterm jaundice has to be taken as pathological unless proved otherwise. Lastly, any baby who is sick, where the jaundice has appeared within 24 hours, or the jaundice is beyond 2 days, the 2 weeks, the baby would be labeled to have a pathological jaundice. The other common complaint that you would have is that of vomiting. What you need to clarify is it regurgitation or spitting out, which is physiological, versus vomiting, which is rarely seen. Most of the times, it is due to the gaseous distension, which causes regurgitation of feeds, but the baby thereafter appears to have a vigorous suck and remains to have a good sleep, cry, and activity. What is important is if this vomiting is persistent, projectile, or bile stained, it is always to be taken as pathological. Fullness of the abdomen, which is tense or guarding, will suggest that again you need to rule out a surgical cause for abdomen, surgical cause for the vomiting. What it means is that vomiting per se, uh, which does not interfere feeding or weight gain pattern, would not be likely to be pathological. The other important thing is to notice the stool pattern, which is blackish in color, what we call it as meconium, which lasts for first 24 to 48 hours, following which you may go on to develop golden colored stools, and these are called as transitional stools. What is equally important is few babies may pass stools once in a week or once in 10 days. This is not to be labeled as constipation. This is a physiological variation, and one should be aware so long as the baby is feeding well and the abdomen is soft, one need not be worried for these. The other common issue for a normal newborn is that of excessive crying. We must realize they do not have a day-night cycle like us. They sleep during the day, remain awake during the night, and therefore these babies appear to have more of a reverse pattern than that of an adult. What is important is cry is a call for help by the newborn. If the baby is hungry or in pain or has discomfort, it will cry. The commonest cause for baby crying is being in hunger or because of discomfort, which is usually because of soiling of the nappies, because of passage of urine or stool. Another common cause is a blocked nose, and the baby finds it difficult to suckle onto the breast. But thereafter, once you put in normal saline drops, once the nose opens up, the baby feeds well. More importantly is crying, which is not associated with change in activity of the baby, feeding pattern of the baby, and most importantly, weight pattern, would be able to identify whether it is physiological or pathological. Lastly, what is important is to identify those babies who are in need of help. Look at these danger signs or red flag signs, and uh, what would require is all babies less than 34 weeks of gestation or below 1,800 grams of weight would require supervised care, either in special care newborn unit or a NICU. At any time, the baby has feeding difficulty, poor feeding, chest indrawing, lack of spontaneous movements, abnormal movements, or appears to be too hot or too cold to touch, one would realize that this is something abnormal, and one would be in a uh, way that one would do a thorough assessment for this baby to rule out an underlying systemic illness. At any times you find yellowish staining of the palms or soles, it would suggest that this is pathological jaundice, and again, such babies would need interventions immediately. So, having seen the care of the baby in the delivery room and thereafter ensuring lactation, looking at three common problems of vomiting, in terms of crying, and stool pattern, let's look at what would be required at the time of hospital discharge for this baby. The baby has to be free from any illness, and more importantly, has been vaccinated. uh, we must ensure that the breastfeeding has been well established, and we must make an attempt to counsel the parents regarding the danger signs. More importantly, the mother should have the confidence that she would be able to care for her newborn. And more importantly, we would schedule this baby for a follow up, which would be depending upon the weight of this baby. So, what have we learned? That care of the normal newborn is essentially care in the delivery room, which involves two important strategies: early skin to skin contact and delayed cord clamping. In the first hour, we would have what is called as early initiation of breastfeeding, which has to be exclusive, and more importantly, zero separation between the mother and the baby. All babies should be evaluated for issue of jaundice, and We identified pathological jaundice based on clinical signs, of which two important parameters that need to be looked at when we evaluate jaundice. One is that of gestation, the other is that of weight. Vomiting, excessive crying is common in the newborn, but more importantly, if the baby is feeding well, is alert, active, and uh, at the end of first week starts gaining weight, rest assured, all is well with the baby. And that would complete our assessment of newborn and care of the newborn at the time of birth. So at this stage, if there are any questions or Dr. Bish would wish to make some comments, or should I move to the next module? Okay. So the first topic was about care of the normal newborn. The second topic is that of thermal control. So if I were to ask you which of the following is a correct statement, let me share with you the choices. A, hypothermia is an independent risk factor for neonatal mortality across all gestational ages. B, mortality increases by 28% per 1 degree Celsius decrease in temperature below the normal temperature. C, hypothermia on admission is a predictor of poor outcome. And D, all of the above, uh, all of the above. So, if you have given D as the correct answer, I think you have understood the relevance and significance of how important is thermal well-being to the newborn. We must realize there are physiological handicaps for the newborn, more so if it is preterm and low birth weight. And this is simply because it has a larger body surface area compared to that of an adult. And it has decreased thermal insulation because of less subcutaneous fat. So also brown fat, what is also called as a powerhouse of energy, which is there in infants, children, and adults, is of limited amount when it comes to low birth weight. And lastly, the ability to conserve heat is not there for newborns, based on which the newborn is predisposed to develop hypothermia. This loss of heat can occur because of conduction, which is coming in contact with a cold source. The commonest example is baby lying on wet linen. It could be because of convection, that means an air current across the baby, and this usually happens if the doors or windows are kept open, and you would have this baby having a convective uh, heat loss. Evaporation occurs because of baby being wet, and radiation is loss of heat to colder areas. And therefore, we must take all efforts to ensure these uh, avenues of heat loss are taken care of in the care of every normal newborn. So, what is expected of us is to give a warm welcome to the newborn at the time of birth. And this is by means of what is called as the warm chain. Cold chain, we are well aware, is a concept established to ensure uh, thermal stability of various vaccines. What is a warm chain is 10 interrelated thermal interventions which are applicable to all the newborns. This includes a warm delivery room, immediate drying, skin to skin contact, early initiation of breastfeeding, delayed bathing and weighing, warm clothing, keeping the baby and mother together, warm transportation, and warm resuscitation. Last but not the least, what is is expected also is health education. So warm chain is a fundamental uh, care for the newborn at the time of birth. So what are good practices in the delivery room? We must ensure temperature of 28 degrees Celsius, 26 to 28 degrees Celsius in the delivery room, ensuring that the fan and AC are kept off and there is no drop of air. Doing the cloth, covering the head always, and wrapping the baby with early skin to skin contact is a simple way to keep the babies warm. Babies are born with vernix caseosa, and there should be no hurry to stop or remove the vernix caseosa. And last but not the least, avoid bathing the baby during the first 24 hours or so. And these simple practices will ensure that the baby goes on to have a warm start. A simple intervention which is overlooked is early initiation of breastfeeding, which is also a simple tool by which the baby gets a good amount of calories, which would help the baby be kept warm. You would document the temperature in the axilla. Rectal thermometer is no longer required, and our target temperature of a normal newborn is 36.5 to 37.5 degrees Celsius. What it means is any temperature below 36.5 degrees Celsius is hypothermia for a newborn, and a temperature above 37.5 degrees Celsius is hyperthermia for the newborn. Every time you have a baby to have a temperature below 36.5 degrees Celsius and up to 36, we would put it as mild hypothermia, also called as cold stress. This is a call for help by the newborn. A temperature between 32 to 36 degrees Celsius is moderate hypothermia and a danger sign for the newborn. And a baby below 32 degrees Celsius will be labeled to have severe hypothermia. What it means is that we should be screening all newborns on admission and all sick newborns periodically to ensure that they have normothermia, avoiding both hypothermia and hyperthermia. The other way by which, without a thermometer, you would be able to test temperature is by means of observing the baby. That is, the color of the trunk and the extremities. In a normal newborn who is normothermic, both the trunk and the extremities appear pink, whereas those babies with mild hypothermia or cold stress would have pale extremities but pink trunk. Dusky extremities with pale trunk suggest moderate to severe hypothermia. So just that looking at the baby's uh, trunk and extremities, the soul would be able to gauge the thermal status. The second option is to touch the baby's extremity and the trunk, which should appear warm equally, which would suggest normothermia. With cold stress, the extremities appear cold, but the trunk appears warm, and with moderate to severe hypothermia, the extremity as well as the trunk appears cold. So even if you don't have a thermometer, by looking at the baby and by touching the baby, you can screen, and those babies who are found to have an abnormality must have a documentation by means of axillary thermometer. We must ensure that throughout the journey from the delivery room to the postnatal ward and thereafter at home, you should be able to support the temperature. And this is possible by means of a simple, low-cost, effective, evidence-based intervention, a tool which not only reduces morbidity but improves chances of survival, and that is called as kangaroo care. This care can be provided by any caretaker. It may be a mother, father, sibling, grandparents. And what it means is that we would target especially babies who are low birth weight, who are stable. And if resources and skills permit, it is feasible to do kangaroo care under supervision, even if the baby is sick. What is important is to ensure kangaroo position, that is placing the baby between the breasts upright, keeping the head turned to one side, slightly extended, ensuring the patency of the airway, having the baby in frog leg position. By that, we mean the hips and the arms are in flex posture, and this would be supported of a pallu or the batta, and making use of KMC sling or binder if it is available. The kangaroo position initially needs to be shown, supported the staff, thereafter the mother, once feels confident can do it on her own. And lastly, there has to be continuous contact between the mother's abdomen, between the baby's abdomen with the mother's epigastrium, which would suggest that there is a appropriate kangaroo position. This is possible provide as early as possible once the baby is stable, as long as possible for at least 1 hour per session with multiple sessions per day. During this process, you should be able to monitor the baby's temperature waving, and ensure that there is no flexion or extension and the baby has an optimal neck position. What is important is that we need to support the mother initially by informing, educating the mother, providing support to the family, and ensuring privacy. What is required is that the baby and the mother should be kept together. We would encourage, in case the mother is not available, other family members to provide kangaroo care. And a simple basic hygiene is all that is expected, and keep the baby and the mother supervised so that no unfortunate event takes place. Today, kangaroo care is a standard of care in the NICU as an adjunct to the ongoing care and has to be advocated, supported, and promoted. What is clearly seen here is the baby head being covered and the baby being uh, wrapped, and so also has clothing which is appropriate for the season. Wrapping the baby is an art which has to be shown to the parents, but a simple way to keep the baby warm is to use season appropriate clothing, ensuring that the head is covered all the time. There are simple, low-cost interventions in the form of a 200 watt a room heater, or a phase change material, which is especially of help during transport, and so also a thermocol box. And an innovation in the form of a temperature watch which beeps if the baby gets cold is an add-on. What is important is that we should be able to manage hypothermia. We said we classify hypothermia based on whether it is mild, moderate, and severe. And based on the degree of severity, the management can take place with the mother or in the special care newborn unit or in the NICU. What is common to mild and moderate hypothermia is continuous provision of skin to skin contact in the form of kangaroo care, ensuring the room is warm, ensuring that the head is covered, and if the baby is stable, one would start and ensure that breastfeeding is continued. Innovative measures to keep the baby warm are equally important. And for babies with severe hypothermia, one would need rapid rewarming up to 34 degrees Celsius under radiant warmer, and then standardized rewarming to reach a temperature of 36.5 degrees under servo control. These are subset of babies who would need oxygen and IV fluids and a check on blood sugars. These babies would be treated with antibiotics unless proved otherwise, and a continuous ongoing monitoring for the next 4 hours is all that is required. What it means is mild to moderate hypothermia can be managed with the mother, and simple interventions can help save the baby from having a further derangement, which would end up, unfortunately, with multi organ damage. Lastly, a temperature beyond 37.5, we would label it as hyperthermia. What is equally important is to ensure that the baby is in cool environment. So get the baby away from the source of heat. Ensure that the room temperature is normal. Get the baby naked, and ensure frequent feeds. Rarely you would need to sponge, and otherwise there is no role of use of routine paracetamol or ice cold water. You would monitor the temperature. More importantly, if the baby shows any clinical signs, you would consider sepsis. Or the commonest cause of hyperthermia in newborn is not sepsis, but environmental temperature because of summer. And sepsis is a diagnosis that should be there at the back of your mind. So hyperthermia requires interventions which are directed towards making the environment as comfortable as possible for the baby. Lastly, with this in background, for thermal care, all babies, especially those with low birth weight, should have additional measures being told and counseled to the parents. This includes skin to skin care, rooming in and a warm room, ensuring adequacy of breastfeeding is important. And at home, we must ensure that the baby is adequately supervised. Mother is told how to detect for thermal instability, both on observation and by touching the baby. And this simple intervention will help save huge number of low birth weight babies, and which will help them to not only thrive uh, and survive in a best possible manner. So let us realize that hypothermia is not because of lack of equipment. It is because of our ignorance. It is a silent killer. It forms a fundamental uh, of basic newborn and advanced newborn care. So we should be able to assess, support, and promote T first, that is thermal care first, before we go on to approach the airway, breathing, circulation, and dextrose. Kangaroo care is a simple, low cost, effective, evidence based intervention for all stable, low birth weight babies. A simple way to make the most of the resources which are available is to promote skin to skin contact and breastfeeding. And last but not the least, at every opportunity, we must introspect and ask, is there an opportunity where we are missing on these principles of care? What are the gaps in care based on our resources and our environment? So thank you very much. And I would be happy to take questions, if any, on the topic of care of the normal newborn and on thermal care, the first module of the SHINE program, the flagship of National Neonatology Forum under the NNF Presidential Action Plan. So thank you so much for your patient listening. Are there any questions in the chat box? So let me know.
Hello, sir.
Yes.
Sir, as of now, we haven't received any questions from the chat box. No.
Okay. So thank you so much for your patient listening and happy learning to you all.
Thank you so much, sir. So, sir, with all your permission, may I end the session over here?
Fine. Okay.
Thank you so much, everyone, for extending us the opportunity to host the session. So, with all your permission, I would like to conclude the session over here and looking forward to host you again. Thank you and good night.